Hi guys, so today we're going to be talking about anticonvulsants or anti-epileptic drugs, also known as AEDs, and specifically we're going to be taking a look at what are some of the key differences between the older first generation medications and the newer third generations. So first of all, we need to go over a little bit of background on the central nervous system itself. So the brain is made up of many types of specialized cells known as neurons. And neurons conduct electrical signals in the form of action potentials. So an action potential will be carried along the length of the neuron until it gets to this area of the neuron known as the axon terminal. And when it gets here, this is going to cause some voltage-gated calcium channels to open, cause an influx of calcium, triggering exocytosis of these vesicles, which contain special chemical messengers known as neurotransmitters. And then these neurotransmitters get released across this space known as the synaptic cleft, across the synapse onto the postsynaptic cell over here, and the neurotransmitters will bind to special receptors on the postsynaptic membrane, known as, in this case, probably ligand-gated ion channels. For example, sodium channels, which would cause these ion channels to open, and then this would begin depolarizing the postsynaptic membrane. So the neuronal membrane has a resting potential of about negative 70 millivolts and a threshold of negative 55 millivolts. So when some neurotransmitters are released and bind to these ligand-gated ion channels, it's going to cause a small local depolarization. It'll become slightly more positive as these sodium channels open up. And if enough sodium channels are opened, and it reaches threshold potential right here, then that triggers opening of voltage-gated sodium channels, which cause a big flood of sodium ions to come in, which is going to bring the membrane up way to about positive 40 millivolts before before potassium ions go out the other way, bringing it back down negative and then eventually back to the resting state. And so these sodium channels remain open for only about 1 millisecond, while the potassium channels remain open for much longer. And this is an all or nothing event, which is shown here by these failed initiations. So if the local membrane change is not enough to reach threshold, these voltage-gated sodium channels do not open and the action potential does not fire. But if threshold is reached, the same characteristic pattern fires every time. Then what exactly is a seizure? So a seizure is defined as a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Essentially what this means is that action potentials in these neurons are firing too frequently. They're happening when they shouldn't be, weird times, there's just too much neuronal activity. And this is mainly due to the ion channels responsible for signaling between neurons. They're not being properly regulated. So there's going to be rapid firing of action potentials. Then epilepsy refers to a range of disorders in which the patient is afflicted with chronic seizures. Now, a seizure can either be symptomatic, which means that the cause of the seizure is known, for example, a brain tumor, or idiopathic, which means there's no known cause. And a lot of seizures actually are idiopathic. And then they can further be classified according to the following three criteria. Onset of action, essentially which areas of the brain are affected. Level of consciousness, which is does the patient lose consciousness? And then motor symptoms. So what kind of symptoms are present? And then this chart here breaks down a variety of different common seizure types. So you can see it broken down into partial versus generalized seizures based on this first criteria, where partial seizures are generally a specific area of the brain, while generalized are on both sides of the brain bilaterally. Then you have level of consciousness varies between the different types of seizures from full consciousness to complete loss of consciousness. And then various symptoms can occur, such as, an absence seizure. You might lose awareness, stare blankly, have a little confusion, while a tonic-clonic seizure, which is the kind most people think of, you're going to have complete, response of falling, muscle jerking, convulsions, biting the tongue, that sort of thing. And then it is really important to correctly diagnose which type of seizure a patient is having, because that will have a big impact on which treatments will be effective. So, brief history of AEDs. First ones really used were in the early 1900s, and these were bromide salts. They were fairly effective, but led to a lot of severe long-term effects, such as bad memory loss, cognitive impairments, really undesirable things. These were replaced in the 20s and 30s by phenobarbital and phenytoin, which emerged as kind of the first more modern treatments. And then over the next century, you start out with first-gen AEDs from late 20s to the mid-60s, which a lot of times discovered serendipitously and often had some pretty unpleasant side effects. Then we moved on to second-gen AEDs through the late 60s to the 70s and 80s, which were often more effective, fewer side effects. Then finally, third-generation AEDs, maybe late 90s through present day, were developed using modern drug discovery techniques such as HTS, hit to lead, SAR, that sort of thing. And these are much more targeted, rational approach and have been able to avoid a lot of earlier side effects. Like I said, today we're going to kind of compare first versus third gen AEDs, specifically through the lens of two similar medications, carbamazepine and lacosamide. So real quick, all AEDs act by somehow modulating either excitatory or inhibitory neuronal transmission. So there can be three general mechanisms you can think of. The first is that they directly act on these postsynaptic ion channels that are involved in that initial depolarization. So for example, those sodium channels, you can have medications that act on those voltage-gated sodium channels that are essential for an action potential to fire. For example, carbamazepine, a first gen, and lacosamide, a third gen, are two voltage-gated sodium channel blockers. You could also have potassium channel blockers, such as gabapentin or pregabalin, or you could also inhibit excitatory transmission. So glutamate is one of the major excitatory neurotransmitters in the brain. So an antagonist of glutamate, such as lamotrigine, would block this excitatory transmission and reduce AP firing. And finally, you can also enhance inhibitory transmission. So GABA, or gamma aminobutyric acid, is one of the main inhibitory transmitters. So if you can enhance its effects, that'll also help reduce action potential firing. And the most common medicines that act through this way are benzodiazepines, such as diazepam and lorazepam. So carbamazepine, like I said, is a first-generation AED and first marketed in 1968. So this is one of the first AEDs developed and marketed entirely by the pharmaceutical industry, just kind of a fun fact there. And it is indicated for complex, partial, and generalized tonic-clonic seizures, while it's ineffective in absent seizures. So like I mentioned earlier about how important an accurate diagnosis is, that's why if you gave this one to someone with absent seizures, it would not help at all. Then carbamazepine is also often considered the gold standard against which new AEDs are compared. So essentially this just means that when a new third generation med is being developed, you want to make sure that it is at least as effective as carbamazepine, because if it doesn't work as well, then why are we bothering developing a new one? And then it has a fairly slow onset, about 3 to 8 hours to reach max plasma concentration, and a long duration of about 26.2 hours for its half-life. And the structure of carbamazepine can be seen right here. It belongs to a class known as the aminostilbene class, and the sort of core moiety of that here is this dibenzazepine scaffold, which is 3 fused rings together. And then it's also functionalized by this urea group, which must remain unsubstituted. And carbamazepine's mechanism of action is still not entirely understood, but we have a fairly good idea. So it binds to the inactive state of voltage-gated sodium channels. So looking back at kind of this diagram of the action potential, you'll notice that in that first millisecond after threshold is reached, all the sodium channels open, big influx, and then right at about 1 millisecond, they're inactivated. And what that means is they take on the third conformation that is not the closed or open, but is one where they're inactivated and cannot close and cannot open. So they cannot do anything. And carbamazepine stabilizes this state. So it holds these voltage-gated sodium channels in the inactive form so that when it comes around for that neuron to fire an action potential again, when it again reaches threshold, most of the sodium channels are going to be already inactivated, so they can't open, so you can't have that big influx to fire an action potential. And so this is going to prevent that abnormal excessive action potential firing. That's a hallmark of seizure disorders. Then the metabolism of carbamazepine, the major metabolic pathway is a phase 1 metabolic reaction through CYP450, specifically CYP3A4 and CYP2C8. And it's actually this alkene right here is epoxidized, so it's an alkene epoxidation to make carbamazepine 1011 epoxide, which is then further metabolized through an epoxide hydrolase to this transdiol. And this metabolite is still active, while this is the major inactive one that's excreted. There is another fairly minor metabolic pathway where you can instead have hydroxylation at this position, and then you can have that urea group can kind of be removed, or you can have this aminoquinone formed. Looks like some oxidation occurring here, as well as that part being removed. But these are both pretty minor metabolites that are inactive. And something interesting to note is that since carbamazepine is actually an inducer of CYP3A4 and is also metabolized through CYP3A4, it actually induces its own metabolism, which ends up resulting in increased and faster clearance with prolonged use. So the dose may have to be escalated in order to remain the same level of efficacy. And some common adverse reactions of carbamazepine. So these reactions right here aren't too serious. These are just the more common ones. Most frequently are things like dizziness, drowsiness, nausea, vomiting that affect a pretty decent number of patients, as well as ataxia here at 15%. And ataxia is pretty much like a loss of muscle coordination, loss of fine motor control, difficulty walking and swallowing, a lot of related symptoms like that. And then some other fairly common ones you might have are some issues with speech, some like twitching vertigo, some other weird little CNS disturbances, some potential psychiatric impacts. Actually cause high blood pressure, can cause some skin issues like pruritus, which is itching, or other kinds of rashes, cause some muscle weaknesses and tremors, as well as blurred vision. But these aren't too serious, but you will notice some of these do affect pretty significant numbers of patients. Then, however, there are some very serious adverse effects of carbamazepine, which is where the issue really comes from. So one of the biggest ones is Stevens-Johnson syndrome or toxic epidermal necrolysis. These are two related disorders, not exactly the same. Here's actually a picture of someone with toxic epidermal necrolysis, so you can see that's not a pleasant effect. And what this is, it's a very severe dermatologic reaction that can occur to several different drugs, but one of the most common types of drugs that causes this is old first generation AEDs. And it starts off as a rash and some flu-like symptoms, which over the next few days rapidly progresses to eventually necrosis, so of the skin. So your skin starts dying and rot, as well as it affects the mucosal tissues like your gums, lips, eyes. It's very unpleasant. And when it's less than 30% of skin involvement, that's when it's called SJS, or greater than 30% is when it's called TEN. But this can lead to a number of fatal complications such as pneumonia, sepsis, and multiple organ failure. Requires ICU treatment almost always, and the prognosis varies between maybe 10 to 20% mortality or even up to 100% mortality based on how severely it presents within the first few days. You can also have a number of blood disorders caused by carbamazepine, notably aplastic anemia, which is a suppression of production of all blood cell types, as well as agranulocytus, which is a lowered white cell count. And these can be pretty serious, so regular blood testing does need to be performed. You can also have hepatotoxicity, which is toxicity to the liver, or toxicity to the kidneys, also quite serious. Psychiatric side effects can be fairly mild, such as confusion or agitation, which, not great. But it can also be quite severe, such as psychosis or even greatly increased suicidal ideation. So very serious there. You can also have something called DRESS, which is a form of multi-organ hypersensitivity, which is very serious and life-threatening and can result in a form of systemic shock where it can be quite fatal. And then since carbamazepine does induce a number of CYP450 isoforms, it has a lot of different drug interactions. So not just with other AEDs, but a whole host of other medicines, and especially in epilepsy patients, this is pretty significant because many patients require more than one AED to really manage their condition. So when you have a drug that's causing interactions left and right, that's going to start causing a lot of problems. Now, lacosamide, on the other hand, is a third generation AED approved exactly 50 years later in 2008, and it was approved as an adjunct therapy for partial onset seizures. And it is currently in trials to establish its efficacy both as a monotherapy, so to use lacosamide alone for this seizure disorder, as well as to see if it can treat other types of seizures, which are returning some very promising results so far. So it has been established to have the same efficacy as older AEDs like carbamazepine, but crucially, it has a much safer side effect profile. And part of that is also that it doesn't really have much enzyme induction at all, so it's not interacting with very many drugs. And the structure of lacosamide is shown right here. You'll notice that it does look like a modified amino acid backbone, and that's because it is. You can see that N-alpha carbon carbonyl right there. That has the N terminus has been acylated, and then where the C terminus would be, it's been replaced with this amide and then this benzyl group. So this was derived from SAR studies on the original lead, which was N-acetyl D-alanine benzolamide, which showed activity in animal models of epilepsy. So then using modern drug discovery techniques such as HDS, hit validation, hit to lead, SAR, we were able to develop lacosamide. So it has about a 10-to-1 steric preference for the R enantiomer. That's why it's shown as R-lacosamide. And then any heteroatoms present should be 1 carbon unit from the backbone to maintain activity. So if you'll notice here, this methyl ester, we have 1 carbon heteroatom. So that satisfies that. And then this N-acetyl group can be replaced with a tert-butyl to lose a bit of potency, but anything else has a big drop-off. And then this benzyl group over here is necessary for activity. Now, the mechanism of action of lacosamide is pretty poorly understood and is fairly complicated. And it's thought that it actually has 2 fairly distinct mechanisms of action. I'll get into the first one more, which is essentially that it inhibits excess neuronal activity by enhancing slow inactivation of voltage-gated sodium channels. Slow inactivation, and that's different from carbamazepine and other drugs in this class that all affect fast inactivation. So like I said, that fast inactivation is 1 millisecond after opening during an action potential. So you depolarize, sodium channels open, fast inactivation occurs, and then classical anticonvulsants stabilize that form. Slow inactivation is a similar process that occurs instead over several seconds or longer instead of over just a millisecond or two. This is actually the body's way of allowing for a long-term physiological regulation to control this fast repetitive firing of neurons, such as what's seen in epilepsy. So lacosamide is actually kind of enhancing almost like a natural mechanism the body has to kind of keep this in check. So this is going to reduce the number of voltage-gated sodium channels available over the long term instead of just that short-term stabilization that carbamazepine provides. And this is kind of a more precise and refined approach for sensitivity regulation, because instead of just locking all those fast inactivated channels all in that inactive state, you're much more precisely trying to play on this more nuanced mechanism. And there is a secondary mechanism that some research has pointed to. It's still very unclear what this is or how exactly it works, but lacosamide has some activity on the intracellular phosphoprotein collapsin response mediator protein 2, or CRMP2. And to quote from Foy's here, this is involved in neuronal differentiation and axonal outgrowth induced by brain-derived neurotrophic factor, or BDNF. So essentially, this protein plays some role in the growth of neurons, the growth of these cells within the brain, of forming new neuronal connections, of promoting good brain health. And we know that in treatment-resistant epilepsy, there is some dysregulation occurring with this whole process. So this points to the idea that lacosamide could somehow be neuroprotective for this subset of patients, but there's some very preliminary findings that would require a lot more research to get anything definitive on. And real quickly, its metabolism is a lot more stable than other sodium channel blockers, metabolized mainly through CYP2C19, 60% metabolized, 40% excreted unchanged, and it displays linear kinetics. So oral absorption is actually 100%, which I thought was pretty impressive. Time to max plasma is about 0.5 to 4 hours, so a lot shorter than carbamazepine, and half-life is only about 3 hours, once again much shorter. Then max concentration remains dose dependent across the board. Now, in terms of adverse events for lacosamide, so to quote from Foy's again, compared to other AEDs, lacosamide is generally well tolerated with few serious adverse events. So that's very good. And then ataxia and reductions in motility, which is more of these muscle issues, can occur, but they're generally quite mild and dose dependent and less common than they are with, say, carbamazepine. And really, the only main serious event that can occur is that in patients with a pre-existing heart condition, lacosamide has been shown to cause inactivation of these voltage-gated sodium channels in the heart, which leads to QT prolongation, which can cause arrhythmias, and in worst case scenario, this could be a fatal arrhythmia. But like I said, this is extremely rare. It has not been shown to happen outside of people with an existing arrhythmia or an existing heart condition. But nonetheless, that is fairly serious. And then suicidal ideation or multi-organ hypersensitivity have been reported, but are quite rare. And then once again, it does not induce CYP450 isoforms at therapeutic doses. So this means lacosamide has very few drug-drug interactions. So especially in a disease state such as epilepsy, patients are probably going to be on other AEDs. So this is a really big advantage. And some common adverse effects, just to quickly go over them. Those like headache, dizziness are fairly common, as well as some nausea. We do have a lot of similar side effects to carbamazepine, but you'll notice these are mostly at lower percentages than we saw before. And then, so a non-inferiority trial conducted in 2017 was done head-to-head carbamazepine versus lacosamide, which demonstrated that lacosamide has essentially equal efficacy to carbamazepine, but with fewer adverse events. So the three main findings were: 1, lacosamide can be used as monotherapy; 2, it is non-inferior, or in other words, equally effective as carbamazepine; and 3, it has fewer adverse events than carbamazepine, so it has an improved safety profile. And so what I wanted to point out here is we have the two treatment groups. So in terms of adverse events that are drug-related, 37% occurred for lacosamide, while 46% occurred for carbamazepine. And in terms of serious and severe, those were both 7% here, while 10% there, so higher across all those categories. And then in terms of events that actually had to lead to discontinuation of treatment, 11% happened with lacosamide, but 16% happened with carbamazepine. And one of the biggest areas that there were some pretty significant differences in, I actually summarized over here, which was with differences in a number of serum lab values, which were attributed to carbamazepine having a lot of weird effects on enzyme induction throughout the body, not just on CYP450 enzymes, but just all sorts of bizarre enzyme induction and inhibition really across the board. So, some pretty large variances here, like gamma glutamyl transferase concentrations were high in 8% of lacosamide patients, but 45% of carbamazepine patients, or low concentrations of thyroxine were found in 0.7% of lacosamide, but 13% carbamazepine. So the clinical significance of these wasn't really examined too much for this trial, but long-term, highly altered levels of a number of these really important hormones or other chemical messengers in the body could have a lot of long-term detrimental effects that we'd like to try to avoid. So really the takeaways from this are carbamazepine, first generation AED, lacosamide, third generation, are equally efficacious. However, lacosamide demonstrates a lot of improvements in its safety profile when compared to carbamazepine. And this can be kind of generalized to most first and third gen AEDs, where generally efficacy is fairly similar, but there are a lot of improvements of safety and side effects seen with the third gens. So therefore, overall, third gen AEDs provide essentially the same therapeutic benefit, but with lower risk. And then really the only major drawback to using these third gen AEDs across the board is cost. So Sharing a personal experience real quick, for me, when I take carbamazepine, it costs me about $10 a month. But when I take lacosamide, well, it has to be Vimpat because there is no generic available. It costs $100 a month, and that's after fairly good insurance. So that's 10 times more expensive. And then when you think about patients who might be on, say, Medicare or who might not have prior auth, it just becomes completely unaffordable. So you really have to weigh, safety benefits versus cost is what it comes down to. So that's all I had for today. If you have any other questions, please feel free to contact me. I hope you enjoyed the presentation. Thank you.